So my disclosures, we're very fortunate to have some grant funding from the bodies that you see there. And in addition to acknowledging our land, I want to acknowledge our team. I am speaking on behalf of a group of very many expert and generous transdisciplinary researchers and community members who are acting in the roles of citizen advisors for our work for the last close to 7 years. And I'm also a staff physician with Alberta Health Services and community health center called CUPS, and aged care organization, not-for-profit, called Care West. Just in case you didn't know, this is the program's disclosures. There's been no financial or in-kind support. And I have endeavored to draw upon best practices, my own and others, as well as available scientific literature on the topic of social determinants of health and related concepts to today. Please, by all means, shout with feedback, questions, ideas. I'm really, really excited to be here talking about this with you today. So I want to discuss individual and system level drivers of vulnerability for older people with what we're dubbing complex needs. And we'll get into what we mean by that in just a moment. But this includes mental health and substance use challenges. And I want to share with you some of our learnings and about other projects that I'm aware of on integrated health, housing, and social interventions that help to overcome vulnerability that's arising from the ways in which our society operates and our resources are distributed, so-called structural vulnerability, which we'll get into in just a moment. So here's my game plan. Touching on social determinants of health and this idea of structural vulnerability, in case it's not familiar to you, I want to look at microenvironments where I noticed a lot of practitioners from varied contexts in the chat. That's so nice to see. And so we are, as practitioners, working in environments where we're interacting with others and team members and the environments, and what can we do there? So hopefully there's some practical ideas that you can take away from today, and share with you some work that we did with some Health Canada funding over COVID, and then come back to this whole notion and what's next in our world and hopefully yours. So determinants of health, we've probably been long familiar with these ideas. And sometimes they can seem a bit abstract, I think, to our trainees, or earlier before we're really front and center delivering and working with people in care settings. This is a rendition from CMHA in Ontario that I really liked. Kind of highlights a few more dimensions of the social determinants of health. But tell me, I'll look forward to your feedback, because I wanted to look beyond the individual social determinants of health and think about how they come together and intersect. And especially in the face of pretty narrow social norms as far as what's appropriate behavior for older adults and what values we apply to older adults' lives and being older or aging. And that was my attempt, this long, skinny yellow line there. And how these are all filtered or interface with discriminatory forces that are unfortunately quite alive and well. And ageism, racism, classism, ableism, that is a very short list of the many different isms and power differentials and structures that are at play in people's lives every day. And homeism is one you may not have heard, but that's being coined by a project I have the good fortune to be a part of, the Aging in the Right Place project, led by Dr. Sarah Canham. And all of these coalesce into creating vulnerability and inequities that are related to how our societies structured, and our policies, our resource allocations, the way that people can access or not supports, and prevailing social norms and values. And so this is my crack at kind of conveying visually something that's quite abstract, but I think we all probably have a lot of contact with this in our everyday lives. And sometimes it can lead to quite a lot of, I would call it moral distress. And I have a story that I'd like to share with you to hopefully make this a bit more concrete. And this is a story about John, who I literally was just visiting with. And John is a gentleman I've had the good fortune to know for about 4 years. He's a 70-year-old man from Canmore, and he's an outdoors man. So Canmore is right near Banff, if you've not had the good fortune to go. Having grown up in the Rockies and loving hiking and axe throwing, he has a brown belt in Taekwondo. He had a longtime partner in his 40s, but he didn't marry, and he retired from his work as a utilities worker in his mid-50s with 2 trucks, a house, many friends, and a dog. John was doing contract work after retiring when he began using alcohol more heavily. He was experiencing some depression, and he tried methamphetamine for the first time at age 58, thinking it would be similar to the speed he had used recreationally in his 20s. John described liking the energy and focus he felt from methamphetamine. By his early 60s, John lost his dog, many friends, his house, and 1 truck. He cycled in and out of friends' homes, shelters, and eventually got stuck in the hospital due to deteriorating physical and mental health at age 65, including spinal stenosis impacting his circulation and sensation, very significant and chronic kidney disease, and chronic foot ulcers. He had partial amputations of several toes, and after several months in the hospital, John was discharged to Harbour House, which offered harm reduction housing, and this is where we first met. So this is the beginning of John's story as I knew it, and we'll come back to him in a few minutes. But he is one of many older people in Canada who has experienced late life homelessness. And I just want to share a little bit of data with you. On the left, the circles, the light circles, light blue, shows you a change from the proportion of older people experiencing homelessness, that's greater than 56 years old, was about 6% in 2001, compared to 39% in 2016. And this was internal data from our largest shelter. It's actually Canada's largest shelter. On the right, you can see from 2012 to 2022, the light gray bars are the percentage of older people. Now, this is using yet a different cut point, but we'll talk about that in a moment. And you can see an interesting increase between 2012 and 2018, but then quite a significant drop reported in 2022. Yet, if we are looking at Canadian data, that's in the dark gray bar, that is not what we're seeing, a trend to the reduction. And so this, we're very suspicious, relates to not windfall of housing and supportive care for older people experiencing homelessness, but rather a phenomenon that you may well have a lot of familiarity of, hidden homelessness. Now, you may say, well, people sleeping rough, they're not very hidden. They're right there on the corner of the street. But in fact, a lot of people who are sleeping rough or unsheltered or sheltering in vehicles do so very discreetly. And if they know and have had heads up that police volunteers or by law enforcement officers who are volunteering in the point in time count are coming to count them, they make themselves scarce. And that's in fact what happened here in Calgary this year. Some of the volunteers were part of our law enforcement teams. Couch surfing, staying with family or friends, living in unsustainable rentals and at very high risk or imminent risk of eviction, and being stuck in institutions, particularly hospitals. We call it alternative level of care in Alberta, and I believe that's a term that's used widely. We do not capture that well. Our point in time count in 2022 identified only 30 beds, or 30 people rather, in hospital. And I really doubt that that's an accurate representation based on conversations with transition services. And so these are different dimensions of homelessness that we may not think of when we think of homelessness in Canada, but these are really important and could represent a 50% greater number of people experiencing homelessness than we actually count. So it's really a bit of that iceberg phenomenon. Taking a look here at work from Boston at what is the state of health that people experience who are older shelter users. And these are typically people who have experienced chronic, intermittent, or persistent homelessness. And these geriatric syndromes, as we call them, are occurring at rates that are even greater than people 20 years their senior. So 70 to 80-year-old people would experience these rates of geriatric syndromes compared to people in their 40s and 50s in shelters. And the deprivation, the living rough, the lack of access to care all contribute to what we commonly call unequal aging or premature aging or accelerated aging. They're all kind of different terms we use, but there's really widespread consensus that 50 years of age is considered older or old. Dr. Katrina Mullaney did some lovely work here a couple of years ago, surveying 300 people using shelters, again, our largest shelter in Canada, and invited them to identify the different kinds of chronic health conditions that they were experiencing. And this is what the older group reported. As you can see, widespread and complex constellations of physical and mental health challenges. When it comes to why are people experiencing housing loss, here's a bit of data from our recent count. Income is a big phenomenon. We're seeing this almost every day in the news. Rents that are far in excess of people's incomes. Conflict is another driver of homelessness, and for some, substance use. Substance use is a real cyclical thing. People will oftentimes increase their substance use after experiencing instability in their housing, and substance use is a contributor for some people's housing instability. But it's certainly not the case for everybody. As you can see, our use of food hampers and food banks in Calgary, probably much like is seen in all over the country because of the cost of living, really, really shocking increases from about 98,000 to almost 150,000 hampers distributed 1 year over the next. This is a bit of Toronto data. My apologies, it's a little bit older, but I thank Dr. Alston for kindly sharing this slide. I thought it was quite interesting to look at the similarities in terms of financial stressors, some conflict issues, both with partners, with landlords. This is more of an all-age survey, but a wide array of proximal reasons for people going into homelessness, and really, really big weights in community housing for subsidized housing. The same is here. It's verging on decade long wait lists. And this is, yes, what the average one bedroom in Toronto, I'm guessing, is closer to 2,200 or 2,300 a month now. So when we have our fixed income supports not even covering half of that, it's no shock that we're seeing escalating numbers of homelessness, and particularly older homelessness in this case. So just to look at a few intersections here related to poverty, income gradients and social gradients. One of the social determinants of health I think we all appreciate, but sometimes we may not be as cognizant of how gender and poverty intersect. As you can see, the rates are higher for women in both age brackets related to pay inequities and unpaid work, and lower opportunities to contribute to pensions, CPP type of things. But magically at midnight, when you go from 64 to 65, those are remarkable decreases in poverty. And you can well imagine that if we had pursued the increase in the OAS age of qualifying to 67, that's going to put a whole lot more poverty debt and load onto the provinces, which are not really well equipped, as we are seeing. Here's another dimension to be cognizant of, although I'm sure you are, that uptake of government pensions is highly racialized in Canada. So this is from work that we've done with a professor of history from Thunder Bay, who is now at Mount Royal University here in Calgary. He's an amazing young fellow, Travis Hay, and I'll share more with you in just a moment from this work. I want to pause briefly, as we mentioned John's experience with substance use. Canadian Coalition of Seniors Mental Health did some beautiful work around baby boomers and some cohort effects around attitudes towards drug use and access, and them being very different. And this is in the UK, this is seen in this American literature, this is a widely observed phenomenon, that there is greater exposure and use of substances compared to previous generations. And we aren't really caught up on that in a lot of our frontline and front-facing services and program offerings. Pain drives more people to opioid use, and we have a lot of people who are not certainly not immune to the risks of addiction that can ensue. And if you add in housing instability, social marginalization, isolation, we see a lot of increase in the risks of substance use. And so this, again, back to this intersectionality. Unfortunately, if a person is using substances, particularly street substances, but even legal substances, cannabis, tobacco, they're highly stigmatized in our aged care systems, typically. And Benjamin Hand from the States has put a big recent call out for harm reduction practices, but this goes back to 2002 in CAMH. So this is not a new call, but we're not seeing a lot of it. And so just want to share a couple of high points. I'm sorry for the busyness of this slide. This is about a 70-page document in the full report, if anyone is interested, but it's got a great executive summary. We looked at 4 policy pillars, and just to start with harm reduction, where we're sitting here, at a federal level, we had harm reduction references in our drug strategy in 1987, and our first supervised consumption site in North America was opened in Vancouver. That would be Insight in 2003. We then saw a real plummet in support federally for and a return to the war on drugs thinking and criminalization of people who use drugs. But by 2017, we had a resurgence of awareness and support officially for harm reduction practice. Now, that's quite interesting to me when I look at the Alberta landscape, and I've been here since 1999, and I learned late in my second decade of practice that we had a robust harm reduction policy in 2015 that was expanded in 2019. We also opened our first supervised consumption site, 16 years after the first one in Canada. And sadly, there have been significant reductions in the support for harm reduction endeavors. Closures, threats of closures, a so-called impact report that has been widely criticized as being not scientific and terribly biased. And we've also had a real constriction on our ability as physicians and nurse practitioners to provide anything but Suboxone, methadone, and Cadian to people with opioid use disorder. You have to go to one of 4 urban centers in the province if you wish to participate in injectable or oral opioids other than those 3 for treatment of opioid use disorder. It's led to court injunctions. It's a really, really big source of difficulty. Continuing care policy in Alberta, like I think many, in many provincial policies, is very focused on keeping people in their homes and providing home-based support. This has come up as the main thrust of policy repeatedly, including post-COVID reform reviews. Sadly, that kind of leaves folks like John out of the picture, because even if you are lucky enough to secure a shelter bed, many home care services are not available in shelter in Alberta anyways. Not to diminish home care at all, it's just not a model of care that meets a lot of people's needs. There's also a really, really rigid response to any substance use, including tobacco use, if you use it outside of the sanctioned areas and times. And rehabilitation is conceptualized only in terms of physical rehabilitation, not mental health or addiction or substance use rehabilitation. So these are the prevailing policy and system structures in our province. And then housing policy presents another interesting constellation of challenges and what I would say is opportunities. So without going into a lot of detail, because I hope it's familiar to you, the housing and social investments that happened post-World War II took us from very few to many, many, many units of affordable housing. Unfortunately, in the 1980s, that building stopped and cuts were made to maintaining those, which we are certainly seeing still the impacts of. There was a handover of housing to the provinces in the mid-90s, and in Alberta, we had a concurrent period of severe austerity and perceived economic downturn. We can see an associated increase in homelessness of almost 350% in that 10-year period in Calgary. And that gave birth to 10-year plans to end homelessness, which Calgary was a leader in the country, really, in low barrier, scattered site housing first type of offerings, which made a really impressive reduction in homelessness overall. But you can see that here's that number again. Between 2001 and 2016, we had almost a 360% increase in older shelter use and homelessness. We have an ongoing issue that we had an interesting opportunity to identify during COVID when we had an assisted self-isolation site. It was a Days Inn that was converted into a fantastic, supportive self-isolation site that unfortunately, despite identifying 25% of the users of that space had complex needs that were beyond those of the available shelters, we were not able to make the case successfully to the province to keep it open. Last but not least, and reflective of an incredible overrepresentation of older Indigenous adults in experiencing homelessness in Canada, is the largely there's a lot of attribution to federal policy contributing to Indigenous homelessness, including the rules that go back to the 50s and were reinforced in the 80s, where people lost their status for interesting things like joining the military or women marrying outside of their nation, intergenerational trauma, as we hear a lot about and see and hopefully are each in our own ways working towards reconciliation, as well as the forcible removal of children from their families, and then jurisdictional disputes that typically happen between federal and provincial bodies. And so this was our attempt to capture what are the dimensions of policy and front-facing services and resource allocation that make it difficult to support older people who fall into precarious housing or age into precarious housing, and their needs are not being met. I'm going to assume our audience is familiar with harm reduction principles and definitions, but just to emphasize the notion of incremental and pragmatic positive change is our goal there, not requiring that people stop using the substances. And another way to think about structural vulnerability is through this risk environment framework. This is one of my favorites that researchers from Edmonton introduced me to about 10 years ago. And what it really does is remind us of the different dimensions of environments at immediate practice level, program level, and system level. And these different dimensions of environments, we've been talking a lot about policy just now and some about economics, and helps us to remember and focus on the sources of harm that are not due to individuals' behavior alone, and helps us to see how the social and political institutions that we've constructed contribute to the production of harm. But the cool thing is they also present an opportunity to reduce harm without relying on, John, if you could just stop using meth, everything would be perfect, right? Instead, we can work through the environment. And this is what I want to share with you, because this is where I met John. Harbor House, which is a pseudonym, is a 68-bed facility that opened in 2005 here in Calgary to try and address the growing number of older people in shelters whose needs exceeded shelters, and there was basically nowhere to house them. They initially planned to be a transitional service type of transitional housing, but there was nowhere to transition to them to, so they quickly adapted to being permanent housing. And full meal service, 2 snacks, housekeeping supports, on-site laundry, in-house social workers. I was part of the visiting health team, and we had nurse practitioners, home care nurses on site, vendored healthcare aides who the vendor agreed to trying to support the same pool regularly going rather than a rotating roster of them. Assertive community treatment, psychiatry and team saw about 10 of our residents. And we did end up with some amazing geriatric medicine consult support for a period. I had the good fortune to work with the organization running Harbor House, and then a postdoc researcher, Dr. Victoria Burns, who's now at our own Calgary Faculty of Social Work, because we were very interested in how harm reduction policy impacted people's lives and work in this setting. We hadn't seen a lot of literature on this in Canada, some from the States. It's really nice. But in a nutshell, what we learned from this qualitative study was that when you are supported as a staff person by your policy to accept that people are going to use substances, people have behaviors that can sometimes be challenging, and instead of making assumptions about that or excluding them from your care environment, you actually seize the opportunity to get to know people and express interest and respect for them. And that was really noticed by the residents, and they really appreciated some freedoms to do what they needed to do, and express their preferences. And trusting relationships were something that we heard a lot about forming in this environment. And it came from many phenomenon, including the opportunity to interact in small ways on a day-to-day basis, including the visiting staff who were part of a core team, the home care staff who were, like I said, dedicated to the site. And in so developing this trust, and I'm sorry, I think I skipped over the harm reduction programs that developed organically in this setting. Harbor House was one of the very few, and still is one of the very few sites in Calgary to offer an indoor smoking area. And it's quite remarkable to me that we assume people will magically stop needing tobacco when they move into assisted living. Managed alcohol and managed tobacco supports, highly tailored to individuals, just was something that the social worker there recognized a need for long before the terms became vogue. And so by really understanding people's patterns and having that relationship where you felt regarded as an older person, and as staff, you felt you knew people, they were able to create these modified microenvironments where staff could actually come in when a person was using alcohol in a binge fashion and remove excess alcohol, put it in storage for another time. And it didn't create big conflicts with people. It was accepted. Those kinds of supports were remarkably accepted compared to in other situations where people would not engage in care, shared care, you could call it. So we went on with the support of the agency running this program. to study the cost savings, or pardon me, the healthcare costs associated with move-in. So 3 years prior to 3 years after move-in, that's the big gray arrow in the middle here. We were able to secure data going back to when the facility opened. And of the about 184 people, 158, we actually had this 3-year pre and post data. And you can see an almost $15,000 savings in the 3 years after moving in, and just a remarkable change in the trajectory of total healthcare costs and hospital costs. So take you back to John here for a minute. And John came to Harbour House just prior to the beginning of the COVID pandemic. And we worked together in a few different capacities, including with me providing his primary care and coordinating his specialist care, especially related to his kidneys and his vascular issues. And he developed a really strong bond with the home care nursing team. You betcha. Thanks, Fran. And so John actually was a big part of a 3-year Health Canada project that we were able to bring to Harbour House. And I want to just focus on the therapeutic recreation programming, because we presented that to Health Canada as a form of harm reduction. And in introducing that programming, we struck a citizen advisory group, the Exchange, which we're still working with. And 5 years later, still securing new funds, and we're super grateful to them. This gives you a little bit of an idea of the level of serious mental illness. 54 out of 62 residents were diagnosed with serious mental illness, and 9 of those 54 people did not use substances of any kind, and the rest used a mix, as you can see there. For the people who did not have a serious mental illness diagnosis, they were all using tobacco plus other substances. And so we had incredible participation. Gray is the first year, and you can see that this was April of 2020 when public health measures shut us down. So after a great start, we had to rebuild a little bit, but we got up to almost 90% participation and sustained that in the blue line. Sorry for the overlap here. We had 2 outbreaks in the second year of COVID that really slowed us down. But by the second one, you can see that the team had figured out how to offer a lot of one-on-one programming. People described confidence, new confidence, doing things that they never thought they'd do. They described quality of life, holistic measures of quality of life that significantly improved. And they set goals at a remarkable rate. And this was behavior from our previous study that had been identified by the social worker as perceived as just another way to fail. And so that confidence translated into some really interesting behavior changes that we captured in our qualitative data, and including supporting one another to be more active, socially especially. We created a film with the residents, and John was a starring member in this film. And if you have interest, it's about 20 minutes, and we're really proud of that. Unfortunately, things didn't go as we'd hoped. We couldn't overcome the changes in strategic priorities in the agencies that were working in Harbour House to get ongoing funding for the initiative. And in fact, changes even beyond that resulted in reduction of the on-site basic supports, including the outreach primary care. There's been a very large turnover in the staff, and they've transitioned their model of care with a focus only on alcohol harm reduction and a transitional model of care. Unfortunately, John experienced quite a relapse in his mental ill health and substance use, and he was evicted about 6 months after. Spent many months in hospital, slept rough, experienced deep-seated infection in one of his legs, last summer sustained an above the knee amputation as a result of that infection. And after several more months of shelter and rough sleeping, he actually was offered a bed in the facility that I'm now doing outreach to, and that's where I came from this morning. And it's a high support housing facility, permanent supportive housing, and there's a huge ongoing need. This is work that's been done in Toronto with therapeutic recreation. I just wanted to draw attention to that. Here are a couple of examples of some really fantastic work that's going on across our country related to similar sort of approaches. And this is our program of research, which we're very grateful to be able to continue with the exchange. And we're talking about successful aging through arts-based methods with them now. And we have funds from CIHR and invite you, should you have any interest in joining us at the Canadian Geriatric Society or in other formats. We're probably going to have some Zoom meetings. Please don't hesitate to reach out. I would really welcome you. Our website has a user guide. If you think there's a role for therapeutic recreation grounded in harm reduction, there's quite a lot of nuances to it. And there's a few other resources that you may already know of, but I thought might be nice to highlight. So thanks so much.
Wonderful. Thank you so much. That was wonderful. And as a rec therapist, I was very excited to be a part of this today and to witness this great work that you're doing.
Thank you.
I would like to open it up for a few questions. We are slightly past time right now, so we can open up for just a couple of questions. You're welcome to put it into the chat or go ahead and if you want to raise your hand and speak up, that would be great. And Donna Lee in the chat is asking if we can post that website again. If I can get someone to post that, that'd be great. It looks like Claire has a question.
Hi, Lara. I think I just mostly want to thank you for doing this work. It takes special people. I was fortunate enough to be in the HIV/AIDS movement when the things were progressing in the government, and safe injection sites were starting to catch on in harm reduction. And I'm disappointed to hear that it sounds like the government is turning and not practicing what they're preaching. Because they are speaking harm reduction, but clearly based on what you've described here, they're not necessarily putting their money where their mouths are. So I wanted to say that, but thank you also. And to tell you, I just, every once in a while I sit through a presentation and get very impassioned in my own home office sitting here, and I might accidentally volunteer myself for many things if I talk too long, but I'll get in touch with you to see how CCSMH can get the word out about some of this that you've talked about here. Some of this is very new to me, and I'm not sure we're talking about it enough.
Thank you so much. Really appreciate your interest and your, yeah, that's super kind. Thank you.
Wonderful. Thank you very much. Any questions? If not, we will go ahead and move on to our case presenter. Thank you very much, Dr. Laura Nixon. That was a wonderful presentation.